Introduction. Welcome. Today we're diving into a rare but potentially life-threatening heart condition called Catecholaminergic Polymorphic Ventricular Tachycardia, or CPVT. This disorder primarily affects children and young adults, causing a dangerously fast and irregular heartbeat in response to stress or exercise. Understanding CPVT is crucial for early diagnosis and effective management. Etiology. A cause of CPVT is primarily a genetic condition. In most cases, it's caused by mutations in genes that regulate calcium handling within heart muscle cells. The most common culprit is the RYR2 gene, which encodes the cardiac ryanodine receptor, a calcium channel crucial for heart muscle contraction. Mutations in the SESQ2 gene, which encodes calsequestrin 2, another calcium handling protein, are also known to cause CPVT. While less common, mutations in other genes like TCRL and CLM1 can also contribute. These genetic defects disrupt the normal flow of calcium within heart cells, setting the stage for abnormal heart rhythms. Pathophysiology. Let's break down the how. Normally, heart muscle contraction relies on a tightly controlled release and uptake of calcium. In CPVT, the genetic mutations we discussed cause the ryanodine receptor to become leaky during exercise or emotional stress. This abnormal calcium release triggers ventricular arrhythmias, specifically polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia is a rapid, irregular heartbeat originating from the ventricles, the heart's lower chambers, characterized by QRS complexes that continuously change in shape and amplitude on an ECG. This can quickly lead to fainting, cardiac arrest, and even sudden death if not treated promptly. Epidemiology. CPVT is considered a rare disease, but its exact prevalence is difficult to determine as it can be underdiagnosed. Estimates suggest it affects about 1 in 10,000 people. Because it's genetically determined, CPVT can occur in individuals of any ethnicity. The typical age of onset is during childhood or adolescence, but it can sometimes manifest later in life. Family history plays a significant role as CPVT is often inherited in an autosomal dominant pattern, meaning only one copy of the mutated gene is needed to cause the disorder. Signs and symptoms. The hallmark of CPVT is fainting or syncope, especially during exercise or periods of emotional stress. Palpitations, or a feeling of a racing or fluttering heart, are also common. Some individuals may experience dizziness or lightheadedness before fainting. In severe cases, the first sign of CPVT can be sudden cardiac arrest. It's important to remember that some individuals with CPVT may have no symptoms at all until a life-threatening event occurs, highlighting the importance of genetic screening for at-risk family members. Diagnosis. Diagnosing CPVT involves a combination of clinical evaluation, electrocardiography, and genetic testing. An exercise stress test is crucial, as it can often provoke the characteristic polymorphic ventricular tachycardia. The ECG during the stress test will show the telltale irregular heart rhythm. Genetic testing is used to identify mutations in the RYR2, SESQ2, or other related genes, confirming the diagnosis. A thorough family history is also essential to assess the likelihood of inherited CPVT. In some cases, implantable loop recorders may be used to monitor heart rhythm over longer periods. Classifications. Types, if applicable. While we don't classify CPVT into distinct types based on different clinical presentations, we do categorize it based on the specific gene mutation involved. For example, CPV caused by RYR2 mutations might be referred to as CPVT, and CPVT caused by Cas2 mutations as SCPT. This distinction is important for understanding the underlying mechanisms and may influence treatment strategies, although current management is fairly consistent across different genetic subtypes. Treatment and management. The primary goals of CPVT treatment are to prevent life-threatening arrhythmias and reduce the risk of sudden cardiac death. Lifestyle modifications are crucial, including avoiding strenuous exercise and emotional stressors that trigger symptoms. Beta blockers, such as propranolol or metoprolol, are the first-line medication, as they help to slow the heart rate and reduce the likelihood of arrhythmias. Flecainide, an antiarrhythmic drug, can be used in combination with beta blockers, especially in cases where beta blockers alone are not sufficient. In high-risk individuals, an implantable cardioverter defibrillator, or ICD, may be recommended. This device continuously monitors heart rhythm and delivers an electrical shock to restore a normal heartbeat if a dangerous arrhythmia occurs. Cardiac sympathetic denervation, a surgical procedure, can be considered in patients who continue to experience arrhythmias despite medication and ICD therapy. Prevention. Primary prevention focuses on identifying and treating individuals at risk for CPVT before they experience a life-threatening event. This involves genetic screening of family members of individuals diagnosed with CPVT. Avoiding triggers, such as intense exercise and emotional stress, is also essential. Secondary prevention involves managing diagnosed individuals to prevent recurrent arrhythmias and sudden cardiac death using medications, lifestyle modifications, and, when necessary, an ICD. Early diagnosis and appropriate management are key to improving outcomes in CPT. Prognosis, recent research or advances, if available. The prognosis for individuals with CPVT depends on several factors, including the severity of the disease, the effectiveness of treatment, and adherence to lifestyle modifications. With appropriate management, many individuals with CPVT can live relatively normal lives. However, the risk of sudden cardiac death remains, even with treatment, emphasizing the importance of ongoing monitoring and follow-up. Recent research is focused on developing more targeted therapies for CPT, including gene therapy approaches to correct the underlying genetic defects. Studies are also investigating the role of different beta blockers and antiarrhythmic drugs in preventing arrhythmias. Advances in cardiac imaging and electrophysiology are also helping to improve our understanding of the mechanisms underlying CPVT and identify individuals at highest risk. Ongoing research offers hope for improved treatments and better outcomes for individuals living with CPVT.